Hello class, this video is for week 1, day 3. Out on my back patio here. If you hear some sounds of nature, enjoy. But what I'm going to do is I want to go quickly through some of the slides, some of the PowerPoints that you have posted on Blackboard. Since we'll be having a quiz Thursday, you might want to take notes from these videos because things that are mentioned here might be on the quiz. So let me just go through quickly. I'll try to keep these videos to 15-20 minutes maybe. But just to go through some of the slides here on Chapter 1, and some of this stuff you've already done, so I'm just going to kind of add to some of the things that you've learned in the book that we talked about in the assignments already. As I stated, I think to some of you, modern surgery may not be modern to you. You think of modern as maybe 2000 or 1990, but I'm a little older than you are, and I'm going further back in history. Some of the major improvements that promoted and led to some of the modern surgical techniques we have today, as stated in the book: pain management, which includes anesthesia, the ability to put a patient to sleep, whereas before, as I stated, they would have to hold a patient down and wait until they passed out before they could complete the surgery. And so they actually started with the patient awake, which was pretty drastic. So pain management to get the patient to sleep so that the surgeon could take their time and not have to rush so much was a great advance. Controlling bleeding, controlling hemorrhaging was a great advance, especially once a surgeon would cut into the skin. There are miles and miles. I think there's about 80,000 miles of vessels in the average human body. We're talking about down to the capillary size, the arteries, the vessels, all the way down to the arterioles and the venules and the capillaries. If you remember your anatomy, I think you've all had A&P. So to be able to control the bleeding, and we've discussed some of those already, how to ligate a vessel where it would just be tied off with suture. It could be clamped with an instrument, various ways. Could be controlled with drugs, things like that. We'll talk about those more later. But the third way, besides pain management, controlling hemorrhaging, was the third one is infection control. Surgeon, I think I said, I told some of you surgeons used to do surgery without even washing their hands. They'd go from one patient to the next. They'd keep the same coat on, and it would have blood all over, dried blood. It was sort of a symbol of your the fact that you were an experienced surgeon if you had a coat that was coated in dried blood. So, yeah, we've come a long way. But no gowns, no gloves, no mask, no nothing. Just cut them open, dig in with your hands, go on to the next patient. So once these advances were made, patients started having much better outcomes. Patients used to die from surgery pretty much on a regular basis. Some of the wars, the military engagements, the Civil War was huge. There were a lot of amputations done during the Civil War. A lot of people died. A lot of people would get gangrene infection, if you know much about gangrene, where the tissue starts to die and infection invades the body, and they didn't have the drugs to overcome the infection either. So those were some of the advances that got us into what we call modern surgery in the 1900s. Late 1800s, early 1900s, there were a lot of advances in surgery. So, and you can see some of the timeline in your book. There's table 1.1. Next page, history of surgical technology, allied health professionals. That's what we're kind of referred to as allied health professionals. That just means we're in close association with each other. The surgeon is the main driver to surgical outcomes. The rest of us we support. The surgical technologists, the nurse circulators, other nurses, the anesthesia person, we all support the surgeon. So what our major goal in each surgical case is to keep the surgeon happy, to anticipate what they need once we become more knowledgeable, and whatever that surgeon needs, we've got it. And we anticipate it, we requested somebody to get it if we know he's about to need it. If we start to run out of sponges, we don't hand the surgeon the last sponge and hope he doesn't need another one. If we hand the surgeon the final sponge, or the next to the last sponge even, we've already requested our circulator to get us more sponges. Sponges are cheap, but when a surgeon needs it, and this is important to know, when a surgeon needs something, he needs it right then. Not when you can get it, but he needs it right then. And that's one of our major responsibilities, is to pay attention, focus, and anticipate, often for hours at a time. Most surgical cases are going to run an hour and a half to 2 hours, maybe 2.5. So for that period of time, you're right there in the heat of battle with them. But time really flies when you're working. It's tremendously interesting, but time really flies, and that 2 hours will go by very quickly. One of the things that I do in the lab is I even show you how to stand, because you can't stand knock-kneed in one place for 2 hours. You can cut off blood flow and you can pass out. So we teach you how to move your body, how to position yourself to remain in a sterile situation, with your hands above your waist and so forth, and still stay focused, because you have to be alert, stay focused, know what's going on, and stay organized. So we're what we call an allied health professional. Just a little history here on how surgical technology started, and you've read some of this already. Originally, nurses were the scrub persons. They scrubbed into cases. After some of the wars, namely, I think it was World War II, the World Wars caused so much injury and trauma that this really made surgery take off. Corpsmen were military personnel operating out in the field. Well, not operating, but just trying to do basic medical care, stop bleeding, and get wounded soldiers back to the doctors. But after the wars were over, you had all these trained corpsmen who were looking for jobs, and so the nurses established a formal training program called the Association of Operating Room Technicians, AORT. This was a formal training program for corpsmen to learn to assist a surgeon. So the corpsmen started scrubbing in, and the nurses started to circulate. I maintain because the job is harder and more physically demanding. So that's why I think scrubbing is harder than circulating. Well, it is harder than circulating. There are some nurses who only circulate. There are some nurses who will scrub and circulate. So the nurses who scrub are the same as we are. They know they can handle the work. They know how hard it is. Nurses who do not scrub sometimes need a little education and don't exactly know how difficult our job is, because a good surgical technologist will make the job look easy, and it's a lot easier. It makes it look easier than it is. But anyway, about 1968, nurses created AORT, the Association of Operating Room Technicians. And then in the 70s, I think it was, the Association of Surgical Technologists formed, and they changed the ORT, Operating Room Technician, name to surgical technologists to be more representative of what it is this job was actually doing. Because this job has evolved. It's not an instrument passer. It has evolved into a position where we know the anatomy, we know the specialties we work in, we know medications, we know instruments, we know the steps to surgical cases, which can run, there can be 300, 400 different steps to a surgery. And you sort of have to do them to learn them. You can't study them in a book, you have to do them. But the job has evolved quite a bit to where we are the right-hand person to a surgeon. We are the most valuable person the surgeon needs because we're right there when it's happening. But in any surgical case, you will require at least 4 people now. It requires a surgeon, a surgical technologist, a circulating nurse, and an anesthesia person. The anesthesia person will typically be a CRNA, certified registered nurse anesthetist. They're not doctors. There will be an anesthesiologist, MD, in each hospital, sometimes more than one in each hospital, depending on how big it is. They will be roaming the hospital, making sure that the ORs are functioning properly and that the CRNAs are functioning okay. If the CRNA runs into trouble, they will page the anesthesiologist MD, and they will come in and resolve their problem and keep moving. But you need at least 4 people in a room. A surgeon can't do the surgery himself. He has to have somebody to set the room up, do it in a sterile way, get all the numerous items required ready and available, and then help direct the patient and pass the items that they need when they need them. The circulating nurse, their job is to, they have to key in stuff in a computer, all the items used during the case. They keep records. They do all kinds of records in their computer. They sort of observe the case, but if we need something, we're scrubbed in. If the surgeon needs something or we need something, then we ask the circulator to go get it. And we practice how to deliver stuff in a sterile fashion so it doesn't get contaminated. But the circulating nurse is the only one that can leave the room. They're not scrubbed in. They're in their scrubs, sitting over at their computer. And so we work quite close as a team with the nurse, with the circulating nurse. In each case, there will be 3 phases of surgical case management: preoperative, intraoperative, and postoperative. Preoperative is everything to do with getting the case ready. Starts from the time the patient fasts on the night before, to checking in, to getting sedated, to getting their clothes off and their gowns on, getting their IV started. All that occurs back in near the PACU area. Check-in, pre-op, whatever you want to call it. And then when they're rolled in on their stretcher to the OR room, they're rolled in usually by the CRNA and the circulating nurse while we are in the room already setting up the sterile bag table, getting all the instruments ready, and getting organized. Once the surgery, and there's a lot of things that goes on between these steps, and we'll get to those as we go through the program. But the intraoperative phase occurs when the surgery is being performed. That's intraoperative, that is inside the operation stage. That's when all these stages are critical. The intraoperative stage is when the skin is cut, the bleeding is ligated, the organs are handled, the tissues are handled, and so forth. That's the intraoperative stage. Once the incision has been stitched, once the surgery is over, the incision is stitched up, the wound is covered. All this is critical to preventing infection. The wound is covered, and then the post-operative stage begins. That's when the patient is rolled out of the room. They go on their way to PACU, which is a part of the hospital where it's called post-anesthesia post-anesthesia care unit. And this is where a different nurse trained in PACU will monitor the wound, monitor the patient's vitals, try to wake them up, get them ready to leave or go back to a hospital bed, whatever. So those are the main 3 stages. Make sure there's a big list of stuff in the book on each category in these. So study through those. Let's see. So sterile and non-sterile team members. Slide number 9, I think. The circulator is a non-sterile team member. They're not gowned and gloved. Sterile team member is only the gowned and gloved. That's us and the surgeon. So the circulator, the anesthesia provider, CRNA, there may be a radiology tech come in with a C-arm, with the x-ray machine. They're not scrubbed in either. So various people will come in and out of the room. And we try to limit that because we don't like the doors being open, because these rooms are controlled by airflow and several other things, temperature, so we'll get into those things later too. The sterile team members, sterile surgical team members include the surgeon, include the first scrub surgical tech, the second scrub surgical tech, and sometimes may include a surgical first assist, which those guys sometimes work for the surgeon. Sometimes they work on their own for several surgeons. They're kind of a little specialty category. They can do exactly what we do and did for several years, and then they got some additional training and learned how to close skin and do the stitching part while the surgeon could go on and do something else. But for the most part, the surgeon will close their own wounds, and that will be the first scrub and the second scrub. The first scrub is the one that has the most responsibility, because they're up there passing everything to the surgeon and making sure the surgeon has what they need. The second scrub typically will be somebody who will just assist as needed, as requested. They will hold retractors to hold the wound open so the surgeon can do their work. Second scrub is not a lot of fun. It's a lot of work, but there's a lot more standing in one place as a second scrub than there is a first scrub. The first scrub is able to move around between the back table and the surgical site, and has responsibility more so than the second scrub. So when you start your clinicals, you may be second scrub the first day or so they can check you out and see if you know your sterile technique. If you look like you're ready to step up and start helping the surgeon, start passing to the surgeon. If you know your instruments, you have to know your instruments, you have to know the technique, and and there's a lot to learn as you go, but you got to get the fundamentals down, and that's what we do at school. So we have also, let's see, page 11 here, the American College of Surgeons. There's about 14 specialties in surgery that they recognize, from OBGYN to eyes to ortho to neuro to ENT. The American College of Surgeons is an organization that most surgeons participate in, and they have input into the things that we do as well through AST. So let's see, some of the broad categories of surgical procedures. Emergency, obviously that's immediate surgical intervention is required. Urgent care requires treatment within a short period. It's not an emergency, but it needs treatment pretty soon. And then elective, which doesn't have to have surgery today, it can be performed when it's convenient. And those could be total knee replacements, hip replacements, things that are bothering people but can be done later on. And elective surgeries were one of the major surgeries that were eliminated during the COVID-19 process, and it's just now beginning to start back up because hospitals wanted to reserve space for COVID patients, as well as divert resources to the ER and to ICU And plus, patients didn't want to risk getting infected with this invisible disease by having their skin cut up. Because anytime someone comes in for surgery and their skin is cut, there's always the risk of infection. And so, being that a lot of this was unknown, it was very risky, so they cut electives. But those are just beginning to start. Let's see, allied health professionals, yes, we covered that. One of the things that we do, theory and application of sterile technique. You'll hear the term aseptic technique. That this aseptic, A means anti, so we're preventing. Septic means infection, so we're preventing infection. We have certain techniques that we do that have been studied, approved, standardized, evidence-based, practiced in the field. They work. So that's one of the major things we do at Kaiser is we teach you aseptic technique. This prevents infection. It does as much as we know to prevent infection. So you'll want to make sure you become an expert in aseptic technique. We show you how to scrub properly, how to put your gown and gloves on without touching the outside of them. What goes first, second, third, there's an order. Obviously you have your mask on already and your head covered. But we show you all that. But that is what sterile technique means. Sterile technique, aseptic technique, pretty much the same thing. It just means that you're a professional, you're an expert in being in the operating room, able to assist a surgeon in a surgical case, doing all the things that we can possibly do to prevent a patient's tissues from becoming infected. Sometimes it still happens, but we do all we can. So we're going to be professionals in sterile technique. It requires us to have a lot of knowledge. We're going to be providing you with knowledge on where you've already studied human anatomy. Hopefully you remember a lot of that. If not, you go back and review, because we're going to be looking at human anatomy, pathology, some of the things that cause disease, and then surgical procedures later on in the program. Professionalism, page 14, refers to maintaining your competence. Even after you complete our program and go through 4 months of clinicals at a hospital, then you will sit for your certified surgical technologist exam. And you will be ready to pass that. You'll just be reviewing by the time you get to that, because we're going to push you so hard to stay up with your studies. This is a career program. This is not just this is not English or math where you want to do it and get it over with, get a grade and move on. This is what you're going to be doing. Everything we talk about, teach, practice, is exactly what you're going to be doing in real life. So it's pretty serious, and you need to approach it that way. But even after you get certified, you'll be maintaining your competence by ongoing education, ongoing training programs. You have to get so many continuing education credits every year to maintain your certification, but you'll know all about that. But it just basically maintains your competency and commitment to the program. One of the major personal traits that you can bring to this program is honesty. Honesty is huge. If you contaminated something in the operating room, we don't hide it. We immediately confess it, because we want to fix it. Nobody crucifies you for admitting that you made a mistake. So this is different than real life. Real life, you try to get by with stuff because you don't want anybody to know, and you hope it goes away. Surgery, we don't do that. We admit it right then, we fix it, the patient gets out okay. The reason people respect you more if you admit your mistake and we correct it than they do if you hid your mistake and the patient suffers, and then we're all called into the office to testify about what happened, how and why. See, so this is different than real life. we have more respect for people who admit their mistakes than we do for people who try to hide them. If you try to hide a mistake, it scares us because we know, because we, you know, if I were the patient in the operating room, would you admit you made a mistake or not? You know, I hope you would admit it. It gets corrected, and then I come out of the procedure fine. So that's the big difference, and you've got to learn how to do that. We practice that in the lab. I'll test you sometimes. We're pretty smart. I've got ways of testing everybody. Sometimes you don't even know I'm testing you, but I'm testing you just to see what you're made of. So honesty, always honesty. You didn't do your homework. You know, whatever. You admit it. We deal with it and we move on. We respect you because you're honest. We've got to have honesty. Another thing is cooperation. How cooperative are you? Can you work with other people under stress? Because we're all under stress in an OR. We need people who can cooperate. You want to be someone who wants everybody else to succeed and look good. And they want you to succeed and look good. So therefore, we all succeed, and the surgeon says, "Great job, guys." That's what we're looking for. So you want to be cooperative. You also have to learn to be a problem solver and prioritize. You have to prioritize stuff. I try to teach you how to do priority. What's most important? And you'll find out what this means in surgery someday. When maybe you didn't get informed in time that the case was about to start. You have very little time to set up, less than normal. Your surgeon is in a hurry for whatever reason. We don't question. We just react. We respond. So we speed it up. We get the room set up. We get the scalpel ready and the forceps ready. We get the first 5 or 10 things ready that surgeon's going to need. That's priority. We prioritize. We know what he's going to need to start that case. We get that ready. And while he's busy with the first few steps, then we can fill in the gaps for the remaining steps. So that's what's called priority. You know how things are supposed to work. And that's true in any part of your life. You know, it's true in making a recipe. It's true in taking care of your car so you can get to school. Priority. What is priority? Priority is studying and being prepared for exams, not going to the beach or responding to family. You got to control the distractions, and you got to focus on what is priority or what is most important for my career. What's going to get me where I want to go for the long run. You know, there will always be the beach. There will always be family distractions. But what do I need to do right now? So you got to be able to prioritize things and problem solve. I think that's about it for now. I'll get into some of the other things maybe tomorrow, but I've already gone 28 minutes longer than I thought. But you need to read through your textbook. Your textbook is full of information that is gold. Hopefully your textbook leads you into other ideas that you can research, because the healthcare field is fantastic. You want to study something about, and this is the way I want your mindset to be. Like the 3 main advances that got us into modern medicine: pain management, hemostasis for hemorrhages, and infection control. What I want you to start doing is, as you look into hemostasis, well, how does blood even clot? You know, if it's a tiny vessel, you get a scratch on your cut on your skin, it's going to eventually clot, and usually pressure sometimes will help it do that. It will eventually clot, a scab will form, the scab will fall off, and your skin will be back to normal with maybe a little mark on it or something, but it will heal up if there's no infection. So how does that happen? What causes that to happen? Have you ever asked that question? What causes blood to form a scab? Look up the coagulation cascade, because once you start asking these questions, then you'll start seeing terms that you don't know what they mean. You start researching those terms, you start learning stuff. The coagulation, C-O-A-G-U-L-A-T-I-O-N, coagulation cascade is a term that doctors use. And what you want to do to set yourself apart is you want to learn terms that the doctors know. And if they hear in conversation, sometimes they hear you mention these terms, that raises you up a few levels, a few notches, because they think, wow, how do you know what the coagulation cascade is? Well, because you have an inquiring mind. You started looking at hemostasis and blood flow, and you wondered how it even happens. There are platelets in the blood. You studied about platelets before. There's fibrin in the blood, and you can pull up some microscopic pictures of blood clots, and it looks like a spider's web. And all that just happens. You know, that's the way the human body, that's the mystery and the amazingness of the human body, is how it can just, is how it is built to stop blood flow. Unless, of course, it's a larger vessel like a vein or an artery. But it will form the fibrin and the platelets and whatever, they will rush to the site of the hemorrhage, and they will start to form a web that starts to stop the flow of blood, and then it will start to form a scab, which will even completely stop it, and then that scab will heal, fall off, and there you go. I mean, it's incredible. You know, of course, in surgery, if an artery, which is larger, or a larger vessel is cut, it doesn't do that fast enough for the surgeon. And sometimes it won't do it at all because the blood is flowing so fast, because a lot of people in surgery have high blood pressure. So we have chemicals, so we have clamps, we have suture, we have all kinds of ways to stop that flow in surgery. But look up coagulation cascade. Those are the kinds of things that set you apart from other students. Okay, so read your textbook cover to cover. You should read every line in Chapter 1. We'll have this exam Monday. But this is just the first part of the chapter. I'll be going over probably 2 more parts of this chapter in the next few videos. Okay, this one's about 33 minutes. So anyway, hope you've got some good information that you can probably play this back. You can play this back since it's on YouTube. Okay? All right, see you next time.